So I'm going to just let this go right over to John and let him start his discussion on organ crosstalk, which I think is a fascinating conversation and something that I think most of us really don't spend a lot of time thinking about, and how everything interplays with each other, all these organs, and how important it is to keep all of them in a normal physiologic state so you don't have these other unintended consequences. It's never just a single thing.
Right, and that's where you get this title, Organ Crosstalk. And I'm glad you asked me to do this because I didn't know all that much about it myself, and it kind of forced me to look into this and research it. So title this is Organ Crosstalk, and I don't have any disclosures on this, but let's talk about what is organ crosstalk. And the background of it is that if you go back over 70 years, it became apparent that acute kidney injury rarely occurred in isolation. And since the 1950s, they noticed that there was abnormal chest x-rays that were observed frequently as a frequent occurrence whenever somebody had kidney failure. It seemed they also had abnormal pulmonary conditions as well. And so it was these observations that led to the suspicion that there was some type of organ crosstalk occurring here. Also, though, the high rate of mortality seen in acute kidney injury is a result of some underlying systemic response that often leads to multiple organ failures. So based on these facts, there seems to be something below the surface, so to speak, that's going on. And just to have an isolated organ suffer injury, you would think you could keep it to that, and it tends to just completely spread to the other ones. And so what's the definition of organ crosstalk? Well, clinical studies have demonstrated the interactions between the injured kidney and distant organs. There's complex mechanisms of crosstalk have been identified between the injured kidneys and remote organs such as the lungs, liver, heart, gut, brain, and even the hematologic system. So the kidney, as it turns out, is the center of almost the overwhelming majority of organ crosstalk is generated right through the center of it, seems to be the kidney. And if you have cardio-renal crosstalk, you can have renal pulmonary crosstalk, you can have neurorenal, hepatorenal. You can also have immunorenal, where the kidneys directly affect the immune system. And at the bottom, you can just have that it affects the hematological system. And you can have any combination of these. So injury to one organ may result in injury to other organs. It doesn't have to go through the kidney, but the kidney is overwhelmingly the center of where most of this occurs. So you can have any interaction between any other organ. And as you can see, the kidney is usually the heart of where it starts and where it propagates from. But you can have other organ crosstalks. So organ crosstalk is most commonly initiated back to ischemic acute injury again, Joe. Renal ischemia, reperfusion injury occurs in shock, sepsis, organ transplantation, vascular surgery, and we know it occurs in cardiac surgery and in ECMO and any situation where you could have a hypoxic event followed by reperfusion. So ischemic reperfusion injury in the kidney propagates a cascade of vascular inflammatory responses. This is really a take-home slide for anybody who likes to take notes. This is probably one of the most important slides going to be on this talk, because this inflammatory response activates endothelial cell activation. Most people don't think about it on the endothelial cell level, but if you think about what happens here and you realize what happens here is that the endothelial cells become into a pro-inflammatory and a pro-coagulant state of the endothelium, and it's due to its interaction with the white blood cells. So then you have leukocyte adhesion and entrapment. Now this is a hallmark of the inflammatory process, whereby adhesion proteins, something called selectins and integrins, we're going to talk about that, cause the white blood cells to actually adhere to the endothelium. Imagine that your immune system has now begun to attack your own layer, your own endothelial layer. And then you result in compromised microvascular blood flow. It's a result of the endothelium becoming inflamed and narrowed by the white blood cells' adherence, okay? So inflammation and the ischemic kidney triggers leukocyte adhesion molecules, something called integrins and selectins. Integrins are cell membrane receptors that facilitate this adhesion. They become activated. Selectins help coordinate and promote this adhesion of the white blood cells and the platelets in immune responses. So then you have toll-like receptors. These are cell membrane receptors that are on macrophages as part of the immune system, which activate immune cell responses. Then you have transcription factors. These are proteins that are actually involved in transcribing the DNA into RNA. A lot of people don't think about the inflammatory response having anything to do with our DNA or RNA, but actually it's at the heart of it. Because at the cellular level, the very basis of inflammation is the deployment of complex gene expression programs that include hundreds of genes and are activated within minutes after a primary stimulus. In other words, there's an expression of multiple genes that upregulates the cytokines, chemokines, adhesion molecules, receptors, and inflammatory enzymes. Then you have your pro-inflammatory cytokines. This is a signaling molecules that is excreted from the immune cells and they further promote inflammation. So all of these things then travel from that organ into the bloodstream. They go to remote organs where genomic markers of injury are upregulated in that particular organ and phenotypic injury occurs. Phenotypic being now injury specific to that organ then begins to occur. So they've tried to treat this, and what they discovered was when they did selective inhibition of cytokines and adhesion molecules, such as the big one we talk about a lot, tumor necrosis factor A, and intracellular adhesion molecule ICAM1, when they've tried to inhibit these, it failed to demonstrate any global attenuation of both the local and remote organ injury during experimental models of ischemic AKI. So this unsuccessful effort to ameliorate the multi-organ failure with specific anti-inflammatory therapeutics highlights the complexity of this systemic response to kidney injury. So let's look at the complexity of organ crosstalk. Okay, so again, you have the kidney that's at the center of it, and you have different pathophysiologic responses to AKI in each of the remote organs. That's the unique thing, that each organ is actually being affected by different inflammatory responses and mediators. So there's multiple inflammatory pathways that are activated in each organ that represent a unique response to the ischemic AKI. AKI induces remote organ injury in the heart, brain, lungs, liver, and gut, involving multiple different inflammatory pathways. And this happens via pro-inflammatory mediators, innate and adaptive immunity. You know, you have your immunity that you're born with, but then as you live your life and you're exposed to things, now you have your adaptive immunity. This also plays a role in your immune response. Then you have cellular apoptosis. Is that how you say that? Mm-hmm. And this is pre-programmed cell death that your cells automatically have, which are a controlled system of cell death, so that cells just don't die and release their toxins into the bloodstream. It's actually controlled where this doesn't happen. Well, when this spins out of control and you have this cellular death that's going on and there's inflammatory responses, now you have the toxins that are released into the system. Mm-hmm. You then also have a whole physiologic derangement. This is a system-wide derangement of your organs that are affected in this response. And then finally, you have the genomic changes, which are the DNA and RNA responses that I was talking about earlier. So we're going to discuss kidney crosstalk combinations. We're going to discuss the kidney-lung crosstalk. We're going to discuss kidney cardiac, kidney CNS or brain, kidney and liver, and we're going to talk about kidney intestine. So first of all, the kidney-lung crosstalk. So it's a pathological crosstalk between the kidney and the lung, and how AKI leads to ALI, acute lung injury. So if you look there in the lower, like, what is that, 7 o'clock on the clock there, acute kidney injury starts, and it releases oxidative stress, cytokines, chemokines, activated leukocytes, and uremic toxins, right? So then it goes up, and those things affect the lung. And then you have alveolar cell apoptosis, fluid pressure is changed. Then you have a dysregulation of the sodium and water channels. At the alveolar level, if you have a dysregulation of the sodium and water channels, your lung takes on fluid. Mm-hmm. You begin to have pulmonary edema right away. So this relieves also this inflammatory markers by the kidney, leads to increased vascular permeability, again, leading to pulmonary edema. So now you have acute lung injury. The acute lung injury then has inflammatory responses of its own. Okay, but the first thing that happens is the lung doesn't function very well. You become hypoxic. You become hypercapnic. You begin to need higher PEEPs from the ventilator. Then you have barotrauma, possibly. These underlying mechanisms, okay, because of the hypoxia, leads back to decreased renal perfusion, blood gas deterioration, and inflammatory markers as well, which now are injuring the kidney back all over again. So these two are just bouncing back and forth and aggravating each other, just these two alone. This is the most common. AKI induces pathophysiologic effects on the lung via the cellular and soluble mediators. The injured lung, in turn, exacerbates kidney dysfunction through metabolic and biochemical derangements. So the kidney-lung crosstalk. Now, when you talk about ALI, acute lung injury, most of the time it's defined as a ratio of the PaO2 over the FiO2 ratio being less than 300. What does that mean? If you look at the denominator, I put 1.0 there. That's, let's say you're on 100% oxygen on the end ventilator, but your PaO2 is only 80. So the ratio is 80, so you're well below 300. So any combination of FiO2 giving you a result of PaO2 that is less than 300, okay, is defined as acute lung injury as long as it's combined with a chest X-ray that shows bilateral infiltrates not caused by elevated cardiac filling pressures, okay? Just to give you an idea what most people refer to as ALI. So in multi-organ failure, acute kidney injury and acute lung injury occur more frequently together than any other combination of organ systems, and the mortality of nearly 80%. So the ALI, the acute lung injury, is due to volume overload, leukocyte trafficking, uremic toxins, and oxidative stress. The ischemic acute injury results in decreased alveolar fluid in the lungs, clearance via the downregulation of pulmonary epithelial salt and water transporters. These include the epithelial sodium channels, the sodium potassium, ATPase, and the aquaporins, which are water channels. All of these happening in the lung, most of them in the alveolar level, all lead to an imbalance of keeping the lung dry. And all of these are dysregulated, you become pulmonary edema. This results in increased microvascular permeability, pulmonary edema, frequently encountered in the setting of ischemic AKI and multi-organ failure. So here, acute kidney injury leads to lung injury and inflammation, and in turn, the lung injury leads to pulmonary vascular permeability, erythrocyte sludging in the lung capillaries, and interstitial edema, focal alveolar hemorrhage. So think about this for a minute. You have erythrocyte sludging in the capillaries of the lung. You have focal alveolar hemorrhage. What is it you always find most of the time when you do a bronch? You find blood clots. Your lung injury, most of the time, is going to have sludging of the erythrocytes and bleeding inside the alveolar. Inflammatory cell infiltration. So the resulting hypoxemia and hypercapnia from the acute lung injury are then made worse by mechanical ventilation. Paradoxically, the high PEEP creates an increased renal venous pressure, right, which now diminishes renal blood flow and function as well. So in addition to the inflammatory communications, you now have a hemodynamic implication where you have to increase the PEEP. That increases your IVC blood pressure, which increases your renal vein blood pressure. Anytime you increase your blood pressure in the renal vein, it's detrimental to the kidney, and it doesn't take much.
On the outflow.
On the outflow, right, coming out of the kidney. So you're back stuffing, right? So now let's talk about kidney and cardiac crosstalk. Mechanisms of cardiac injury during ischemic AKI include cardiac myocyte apoptosis. So here you have the myocytes of the cardiac cells, unregulated cell death. You have neutrophil infiltration, which we see this in almost all inflammatory responses. They've been attributed to increased cardiac and systemic TNFA again. You have your interleukins. Interleukin-1. Now, when we talked about this yesterday and we'll probably talk about today, that the hemoconcentrator removes a lot of these inflammatories. We talk about interleukin-1, 6, 8. Those are not isolated single entities. Interleukin-1 is actually a group of 11 cytokines that play a central role in the regulation of immune and inflammatory responses to infections and sterile insults. Then you have the ICAM-1, intercellular adhesion molecule. It's a ligand for integrin and causes the leukocytes to bind to the endothelial cells again and then transmigrate into the tissues. So in experimental models, you take animals and you isolate and clamp off the renal artery perfusion, give them ischemic AKI. Within a short period of time, it begins to demonstrate left ventricular dilatation.
And increased lung water.
Well, we were talking about cardiac, right? So this is interesting because if you take, let's say, an animal and you just simply open them up, put them under anesthesia, and you give them ischemic AKI, you begin to see deleterious effects in the cardiac function. Their heart was normal. You then see increased left ventricular end diastolic and systolic diameters, increased relaxation time, which is a fancy way of saying, you're dilating. Decreased ejection fraction. So now let's talk about kidney CNS crosstalk with the brain. The effects of ischemic AKI on the central nervous system are evident clinically when mental status changes develop. So here again, you have somebody who just experienced AKI. They begin to deteriorate their central nervous system. So encephalopathy caused by uremic toxins and inflammatory mediators include KC, which is a cytokine, GCSF, granulocyte colony stimulation factor, gliofibrillary acidic protein, and neutrophils. All these things that most of us aren't too familiar with. You then have an increase of chemokines, resulting in increased vascular permeability in the brain. You have cell-mediated pro-inflammatory response with an activation of microglial cells. These are brain macrophages during ischemic AKI. This is what's going on in the brain. This may result in an alteration of the blood-brain barrier, right? So when you do renal replacement therapy on these patients, it fails to fully correct this CNS manifestation of renal failure. Why? Because just aiding the kidney in its functions, the kidney is failing, you're going to come in with renal replacement therapy and aid the removal of your urea and so on. It's not as simple as that.
Now,
you have all of these inflammatories.
Before you say that, the renal replacement therapy, are you talking about intermittent dialysis, or are you referring to continuous therapy? Which of the renal replacements are you referring to? Well,
usually the intermittent in this case, because I
think that is what you're referring to.
What they were trying to do was say, well, we have a failing kidney. Well, why don't we just go in and help the kidney out, and all this will subside.
Right.
That failed to correct the problem, because you have all of these underlying problems that don't just have to do with the increased level of urea and so on that the kidney's now failing to remove. In kidney-liver crosstalk, you have ischemic AKI has been shown to incite oxidative stress, inflammation, apoptosis again, and tissue damage in the hepatocytes. Oxidative stress during ischemic AKI causes hepatic lipid peroxidation to increase while antioxidant agents decrease. Pro-inflammatory cytokine tissue necrotic factor A expression and hepatic cellular apoptosis is evident again during ischemic AKI. So crosstalk stimulates hepatic stellate cells, which exacerbates leukocyte trafficking and a secretion of chemokines. What about the kidney and the intestine? While the kidney is the engine of the organ crosstalk, it is actually the gut that you can call the driver of multi-organ failure, because its ability to amplify the systemic inflammatory response in the setting of shock and gut hyperperfusion. These mechanisms include increased intestinal permeability, now interactions between the host and bacterial pathogens. Because of the gut, it's unique in that ability to do that, so it's particularly powerful, a negative in multi-organ failure promotion. So propagation of toxins to distant organs via the lymphatic system. So in conclusion, AKI is a frequent complication amongst hospitalized patients with grave implications in the setting of multi-organ failure. Ischemic AKI initiates this cascade of pro-inflammatory pathways and through the release of soluble mediators and activation of host innate and adaptive immune systems, facilitates organ crosstalk and subsequently remote organ injury. So as our understanding of post-ischemic kidney's role in mediating organ crosstalk continues to evolve, it's hoped that the therapeutic treatments we can develop for this devastating complication will emerge. I think that's all I have.
Wow. Okay. Very good. I'll give you an applause on that one. A couple of questions. Joe Bulaki. I hope I'm saying that right. Anil. He's a perfusionist in Mauritius. I don't know where that is. We'll figure it out. But he's asking a number of questions. He's like, what is the value of O2 delivery we need? And I'm assuming he means on bypass. Is it 272, 262, or 230 index per minute per millimeter squared? That was one question. Anybody on the panel can answer this. But he also is asking, what is the hemoglobin level we should keep to prevent AKI? And if we have to add blood to attain the hemoglobin level, are we doing good? Well, I mean, the simple answer to that is the hemoglobin level you need depends on how much O2 you're delivering. So that kind of goes back to the first question. And two, you're never doing good giving blood. Sometimes you have to. You're damned if you do. You're damned if you don't, Joe. But you want to just start down there and kind of come back this way with any comments on those two questions?
I think, anytime, you're on bypass and you always want to try to maintain a decent, H&H just to make sure you have, good, oxygen carrying capacity for your hemoglobin. I know you're on bypass, and depending on if you're cooling the patient, depending on if you're more normothermic or, you're cooling to like 28 degrees, then maybe you might be able to adjust your PO2 and get away with running a low hemoglobin. And then when you come off, see if you can give back a cell saver if you want to, be smart about blood conservation and not having to transfuse, depending on how critical that number is.
Oh, I agree with that too. I think blood is always a last resort. I think this goes back to the talks we were having last night, or y'all were having last night, about ultrafiltration. I think it's a real tool that we can try to use to help us prevent giving blood. Of course, sometimes you have to. Sometimes the patient's, just hemodynamically unstable because their hemoglobin's too low. But I think really that should be our very last resort.
I would agree with that. John, you want to tackle Joe's questions?
It sounds like he might have watched PerfWeb 23 because when we did that one, we refer to those exact three papers. There's three papers on delivery of oxygen that give those exact parameters or levels that they were looking at: 230, 272, and 262. So there's still a lot of research that needs to be done to figure out what is the critical level that we need to stay above. We don't know that, but the general accepted right now seems to be the 272, which is a paper by Ranuzzi out of Italy that's done the most work on this. But so I would suggest that if you're monitoring DO2, try to keep it 272 and above. As far as the hemoglobin goes, when you only look at hemoglobin, you're not seeing the whole picture because you need to look at delivery of oxygen.
Right.
You don't the minimum hemoglobin level depends on how much you're flowing. Look at the delivery of oxygen formula. Hemoglobin is only one of 4 parameters that are going to affect it up or down.
Right.
If you have a lower hemoglobin, you're going to have to flow more. If you have a higher hemoglobin, your delivery of oxygen is going to be greater of what you're carrying. You can flow less. So I don't know that there's a golden rule when it comes to delivery of oxygen and hemoglobin. You need to be delivering enough oxygen. If you're not doing that, you need to up your 4 parameters: blood flow, hemoglobin, PO2, and saturation.
Well, yeah. That's a very good point, and I think that we can kind of take that down another rabbit hole and say that if you could flow enough, essentially, you could have a hemoglobin of 5. The problem with that, though, is, what other, since we know hemoglobin is our strongest buffer in the blood, it's a great buffer. Without it, we're going to be becoming more acidemic just from the anemia, not necessarily from, hypoperfusion, but that non-viscous state more and more, how does that affect things? Are we going to have, can you flow enough with a hemoglobin of 5 to get away with it?
Well, nothing lives in a bubble, right? I mean, so you have to look at, if you're going to an extreme on something, you're probably negatively affecting something else.
Agreed.
Which you begin to do,
And you have to sit there and think about that. Like, what's the consequence of this?
I mean, you couldn't have a hemoglobin of 1 and be flowing 20 liters a minute. Theoretically, maybe your delivery of oxygen says it's okay, but you have to look at nothing just in a bubble by itself. So you have to look at, but we don't, this is a real good area. The delivery of oxygen, especially in regard to how it affects the kidney, is a whole area that we've scratched the surface on, and some people have done a lot of work, so we do know a lot, but I think we really need to have that as a focus. And if we're looking at that in the future as perfusionists.
Well, I want to ask you a question, if I can, regarding the patient with the cardio-renal syndrome that you were talking about, and how correcting the AKI did not improve anything with the heart. And of course, that is a complex relationship, which I think you very eloquently described in your slides and with your work that you did on that. But they saw no improvement with RRT. And I sort of stopped you right there to get from you, are we talking renal replacement therapy as intermittent dialysis, which is only diffusive clearance? Or are we talking about CVVH, where you're removing especially higher doses, inflammatory mediators, and so forth? Because there is a big difference between IHD and continuous therapies, and diffusive therapy versus convective therapy. So I'm I'm curious what your thoughts are on that.
I think,
and whether if they'd have done that type, it would have made a difference that you saw improvement.
I mean, this is really sort of an overview. That's a good question. I really wouldn't say I know the answer to that, but I think you're talking about when this all initially was being looked at some years back, and I don't know the specifics of what they did on that. Yeah, it'd be a good question to look into. I don't know the answer to that. Somebody else out there might know something more about that. But now that we have so many elaborate ways of doing RRT, you may be able to hone in on some benefit of the crosstalk aspect of it. I don't know the answer to that, actually.
I had a quick question for you before I'm going to go ahead and get my talk out of the way. But when you do your hyperkalemia cases, how many liters of ultrafiltrate do you go through to get your potassium cleared, plus or minus?
I mean, we probably go anywhere from, it could be 8 to 12 liters. 8 to 12 liters.
8 to 12?
8 to 12.
Or you think I've done 20. I mean, 8 to 12 would only be 2 of those replacement bags, which are 5 liters each.
Well, we've gone through 5 bags.
5 bags, so that'd be 25 liters.
20. So it'd be, on the highest case, I've done about 25 bags. I mean,
about 25. Okay, 5 bags. So 25. So somewhere between,
more within 12 to 15, and
depending on how much potassium you gave, and whether they're making urine a lot of, and they're losing a lot of potassium, whatever. Okay, so just another real quick question before I get started. On those patients that you've done with the very high volume CVVH to remove the potassium like that, and we're talking about continuous ultrafiltration where you're replacing it with a solution. We're not talking about dehydrating the patient. This is kind of a zero balance, Z-buff, I guess we would call it, right? How many have those patients done?
They've done well.
Has any of them had any issues, especially associated with, failed kidneys in the ICU?
No, kidneys returned fine. Patients did well. Hearts, came back. I mean, depending on how high you get the potassium, sometimes it takes a little time to let the heart reperfuse.
It never gets ischemic.
Exactly, it never gets ischemic. Yeah,
you just have to get the potassium.
Exactly,
out.
Get the potassium out. Basically, that's the main thing. And sometimes, depending on how, every patient is different. Depending on what you need to get the potassium at. But we've gotten the potassium, up pretty high. So it's, it's just a matter of giving time to get it off and timing about when you start actually pulling off, because then, that takes time to pull off too.
Have you done any of the hyperkalemic cases?
I haven't. Actually, I have a question for you. So for those of us who aren't familiar with that, how high are you getting the potassium?
They can be as high as like greater than 9. I mean, we sent it to the lab.
No, they get as high as 18.
18, yeah.
18. Yeah, but sometimes.
When we're coming off, it'll be.
Yeah.
We've came off before at like 6, 6.5, 7. But then, given, medications and, Lasix and whatnot, the patient usually gets it off. But you're right. But it'll be, the lab will send, our ISTAT would only read greater than
9.
Yeah, greater than 9.
Right, but we send it to
we
the
send it to the lab.
But you just said something, and I'm glad you said it finally, because I'm going to get John looped back into this, where then I'm eventually going to get to my talk. But he said he came off the bypass with a potassium of 6 and sometimes 7, and because it's on its way down, he has no problem with it at all. Tell him your story about what you were told.
Yeah, in the last, I don't know how many years, I've seen this alongside the trend that the hemoconcentrator is somehow causing kidney damage. I've also heard this almost like a real paranoia about coming off pump with potassiums, even as high as 5.0 or 5.5. Just wait, refuse to come off. You have to get it down. I've seen this a lot in my travels. I'm not sure where it came from or if it's valid, and maybe I'm wrong, but I know that for many, many years, 70s, 80s, 90s, even early 2000s, people were using a lot of straight Pledgisol. In fact, it's still out there. So you had to give a lot of volume and you had to give a lot of potassium.
And it was all crystalloid.
And it's all so
we didn't have blood.
The hemoconcentrator in and of itself doesn't lower potassium. So we always came off with potassiums that were 5, 5.5, 6, 6.5, even 7. And nobody ever mentioned anything was ill effects about it. I never really saw any ill effects about it. But now, a lot of places I go, I see people treating potassiums that are 5.0, 5.5, forget about it, won't come off pump, they wait.
Really?
And I'm just wondering if that should be a topic we can talk about.
I think so, because
I've also had experience.
And I really, maybe I'm a dinosaur. I didn't.
You are.
I am that, but I try to stay alive though. So I don't. I would love to know how these coming off bypass with high potassium, and I've asked cardiac surgeons directly. Do you think coming off bypass with high potassium is benign? And they've always told me, yes, it's benign. Everyone I've ever asked said that. But there's a bunch out there that I didn't ask that I don't need to ask because they're yelling and screaming in the OR. We're not coming off pump to get the potassium down to 5, even if it's 5.3 or 5.5. Forget about 6.0 or 6.5. We can talk that a whole other day, I think.
We will, but
good
yesterday
topic
you said it was a diuretic. It sounds to me like it'd be a good idea to leave it up there and let the kidney diurese it out itself.
Right?
Your body is gonna, when you return the pulsatile flow, even while you're still on pump, and you begin to fill the heart up a little bit, when the pulsatile flow returns, with the non-pulsatile flow, your sodium-potassium pumps are not working very well. The minute the pulsatile flow begins to return, sodium-potassium pump, every cell in your body begins to push that potassium back inside the cell. And within 1 to 2 minutes of your pulsatile flow returning, because I've done this many times, sample the patient's blood, you'll find a real serious drop in your potassium. Your body's just not going to let it stay up there. It's just not. But even so, what is the negative effect? It's a negative inotrope, negative chronotrope, really, right? When you're coming off bypass, if that's a negative chronotrope, everything we're doing is a positive inotrope or a positive chronotrope. We might be giving a gram of calcium, or maybe the anesthesiologist giving a gram of calcium. They're on epi, they're on dopamine, they're on, all of these positive inotropes are just way overcompensating for a little bit of an elevated potassium. That's a negative chronotrope. So I've never seen a negative effect from it. Never have. And then you're doing this procedure now, and surgeon's probably ready to come off, and you start coming off with higher and higher potassiums. How many times have you done this procedure with that with the high potassium?
Every case, most every case I've done, we've all been come off with at least the potassium. I've had one case where the potassium actually was below 6, but we just started.
The rest
taking
are all
off
above
early.
6.
Right above 6, but above 6 but below 7.
Mm-hmm.
Above 6 but below 7.
Mm-hmm.
I mean, we've had normal cases. I mean, even non-hyperkalemia cases where sometimes the potassium gets up too high, but it's a fast case, and then before you know it, you're rewarming,
Right.
and then you get your next gas back, and then the potassium 6.5, you Z-buff a liter or a liter and a half or even 2 liters, depending on how fast your hemoconcentrate is running, and then you might get it down 6.2, 6.1, but you're still going to come off at that. And I think the patients have done pretty well for the most part. You can give diuretics and get the potassium
If you need to. Or it'll just take care of itself. And getting back to that pulsatile flow, the new artificial hearts, all of the new artificial heart technology, and Dr. Frazier, I think, over at CHI, he's Texas Heart Institute, CHI St. Luke's. He's very passionate about this, but they're all, continuous flow pumps. And so that sodium potassium pump mechanism that you're talking about for the intracellular, extracellular shifting of ions and fluids, is, I think, adaptive at some point. It's just that when we're doing it, it is such a compressed period of time, because there are a lot of patients walking around without a pulse, and they're walking around and doing just fine. So it must be an adaptive process, I think, because
LVAS, heart rate too.
Right. His argument, of course, is the capillaries have continuous flow. There's no pulse in the capillary. And, it's hard to argue with, Dr. Bud Frazier, So it does work. It's just, is it adaptive? I think that's really my question is, because we know that's the case, but for the pump, it's not adaptive because there's no time to adapt. It is just an immediate sort of issue.
So I ran this by our cardiac intensive care nurses. I said, do you guys treat high potassiums? She's like, yeah, our potassium gets, to 5.5, 5.9, we get concerned, and we're concerned about high potassiums, and that's different than bypass, totally different, because on bypass, all the drips are off. The pulsatile flow's off. I mean, you have non-pulsatile flow, you have high potassium possibly because of cardioplasia, but all the drips are off. So your high potassium creeps up. Now we turn all the drips back on, which are positive inotropes, positive chronotropes. The pulsatile flow returns, and the body sees a high potassium, it begins to correct. If you're in the ICU 24, 48 hours, all of your inotropes are going. You have a pulsatile flow, but your potassium's starting to get away from you.
Completely different
So
phenomenon.
a nurse is not going to sit there and let that trend continue to where it gets to 6 and 6.5 and whatever. And now she has a hard time keeping the heart rate up and the blood pressure up.
Right.
See, we have already gone to the point where we're not treating that at all. And we can easily reverse it with what I just said. She's already treating that, or he or she already doing it, and the potassium's getting away from them.
We can make it better just by simply getting the patient off pump.
Well, it did correct. Have you ever drawn a sample? Next time you have a high potassium, literally wait 2 minutes if you can and get the anesthesiologist to give you a blood sample and check the potassium. 2 minutes of pulsatile flow. I bet you see a huge drop in your potassium. I bet the 6.5 is well below 6. 5.5, 5.6, somewhere in there. I've done it many times, I know.
Some of our pumps, we and for some of the cases we do in the Woodlands, there's a pulsatile flow option on the pump. So I'm curious how effective that is.
None. I'll answer the question for you. 0.
Okay.
There's no pulse pressure.
Right.
It's more of a sine
More of
wave,
an
and it's such a
intermittent-
slow,
More of an intermittent pause.
Pretty much.
Basically.
I mean, it's you have to have a pulse pressure of at least, I believe it's 30, in order to really have a benefit from pulsatile. From a pulse wave, not to mention, the upstroke of that thing is, your time matters too. So with normal heart, you have big upstroke, drop down, big upstroke, drop down. You're
not much of a pressure gradient.
No, and it's very slow upstroke and then very slow downstroke. I would say it is only effective at damaging more red blood cells. I don't like doing it. I think it's pointless.